Hello everyone, this is Dr. Gobind Rai Garg. I have chosen one special topic for this video. There are many questions where different teachers are giving different answers, or there are different things written in different books, or different institutes are telling different things about the same concept. So in pharmacology, I will be compiling those topics and we will try to cover those controversies. It will be my perspective. So later on, you should not get confused between these topics. So that's why I have kept the name as controversy crushers. Okay, so let's start. So the first question is, all of the following are responsible for Ipratropium-induced paradoxical bronchoconstriction except. So before going into the question, we'll like to understand what is the meaning of this. If you say ipratropium, as the name tells, it is atropium. That means it is atropine-like drug. Atropine-like drug means anticholinergic, and it is given by inhalational route, given in the name. So ipratropium is primarily M3 blocker. It is a non-selective muscarinic blocker, mainly blocking M3, but also M2 and others also. By blocking M3 receptors on the bronchus, it causes bronchodilation. We know ipratropium is used in asthma, so it is causing bronchodilation. But question is, it can cause bronchoconstriction in some people. Obviously, we are expecting it to cause bronchodilation, but it is causing bronchoconstriction. So that's why it is paradoxical. So question is, why it causes bronchoconstriction in some people? Yeah. The basic concept why it causes bronchoconstriction, the primary reason is that if you want to understand, this is a neuron which is storing acetylcholine. Acetylcholine is stored in this neuron. Now, acetylcholine, whenever released, it will work on the receptors here, which will be M3 receptors mostly. Remember, पहले खाओ पियो, फिर दिल लगाओ, बाकी काम बाद में. So in the bronchus, we have M3 receptors. So acetylcholine stimulate these M3 receptors, which result in bronchoconstriction. Okay? But one receptor is present here also, primarily M2. So this receptor is called presynaptic receptor. If you remember, just like alpha-2 receptor, remember alpha-2? Yes, like alpha-2 receptor, it acts like a brake. What is the meaning of brake? Whenever we stimulate M2 receptor, it will stop the release of acetylcholine. Acetylcholine will not come down. So M2 is acting like a brake. So what happens when we give ipratropium? It not only blocks postsynaptic muscarinic receptor, but it also blocks presynaptic M3 receptors. M2 receptors. So by blocking presynaptic receptor, it causes failure of brakes. Brakes fail. So when the brakes fail, means more acetylcholine is released. When more acetylcholine is released, it stimulates M3 and that causes bronchoconstriction. Clear? So this is paradoxical. But after some time, it will block M3 postsynaptic also. So when it blocks postsynaptic M3, then bronchodilation. So this bronchoconstriction is transient, earlier. Clear? So that is the main reason of bronchoconstriction. Ipratropium can block presynaptic M2 receptor, which can result in enhanced release of acetylcholine that can cause bronchoconstriction. So this is the primary reason. Now, apart from this, the other reason is that there may be some impurities in the nebulizing solution. So when we are giving the nebulization solution contains some impurities. Those impurities include EDTA and benzalkonium chloride. So these irritate the respiratory pathway that can result in bronchoconstriction. And third important reason can be hypertonic saline. So hypertonic saline is itself used in some condition like bronchiolitis. We will discuss the mechanism, but hypertonic saline can irritate the respiratory pathway. It can also result in bronchoconstriction. So if you see this question, it becomes easier. Presence of EDTA, presence of benzalkonium, hypertonic saline all cause bronchoconstriction. So presynaptic stimulation is not causing, it is presynaptic inhibition of M2 receptor which will cause bronchoconstriction. So this is the answer. They have asked except, so this is the answer. Now what is the controversy? Controversy is, in some institutes, they have written presynaptic inhibition here only, but instead of hypertonic saline, they are giving the answer as hypertonic saline do not cause bronchoconstriction. So I feel this is a wrong concept. Hypertonic saline is a strong bronchoconstrictor. Now let's see some references. So this is reference from the pharmacotherapy journal, preservatives in the nebulizer solutions. So they have given EDTA and benzalkonium chloride. and they have clearly tell that they can cause bronchoconstriction. So this is true, there is no controversy. So everyone is agreeing that these cause bronchoconstriction. But the problem is this. If you see that American Academy of Pediatrics journal, it is very clearly writing there is fairly clear dose-response relationship for hypertonic saline and bronchoconstriction. See, hypertonic saline causing bronchoconstriction in patients with asthma. So hypertonic saline causes bronchoconstriction. It do not cause bronchoconstriction is a wrong concept. But what I want to tell is both hyper and hypotonic solutions can cause bronchoconstriction. Both. Remember, not only hypertonic, but hypotonic also cause bronchoconstriction. So let me tell you one thing. Suppose this is the bronchus. Alveoli, we can say. Bronchus, the lumen of the bronchus. Now, when we give hypertonic saline by nebulization, so it will reach the bronchus, lumen of the bronchus. So when hypertonic saline reach the lumen of the bronchus here at this point, what happens? Hypertonic, the solution is hyperosmotic. So hyperosmotic solution, what happens? To make it isosmotic, the water will come from the cells toward this. So the water is removed from the cells and it will come in the alveoli. So hypertonic saline is used to make the secretions less viscous because it attracts water. So secretions will become less viscous and they can be removed. But during this process, the bronchus get irritated and that result in bronchoconstriction. So that is how hypertonic saline works. On the other hand, in hypotonic saline, if there is hypotonic saline, again, this is the bronchus. When we inject hypotonic saline comes inside the lumen. So when it is hypotonic, what will happen? The water which is more in the solution, it will go inside the cells. So hypotonic salines result in swelling up of the cells. And when the cells swell up, they may even burst, they may die. So usually we do not use hypotonic solutions like distilled water by this nebulization. We do not use because they can result in breakdown of cells by causing increased uptake of water by the cells. But the same thing, when more water is uptaken, the cells swell, they get irritated, and that irritation result in bronchoconstriction. So both hypotonic and hypertonic solutions can cause bronchoconstriction. Is it okay? So this concept that hypertonic saline do not cause bronchoconstriction, only hypotonic causes, that is a wrong concept. So what I want to restate is that this question is basically asked on presynaptic stimulation. So remember, ipratropium do not stimulate M2, rather it block M2. Okay. So this controversy is crushed, right? Great. So now we can move to the next controversy. So this is another question which is recently been made controversial unnecessarily, which the following is known as efficacy trial. Now again, before going further, I will want to tell there is no term known as efficacy trial. So efficacy trial per se is not a recognized term, but what is important, efficacy is tested in two phases, both phase 2 as well as phase 3. Remember, in phase 2, efficacy is tested first time. Remember, phase 1 is done in healthy people. When we are testing a drug in healthy people, we will not test for efficacy. It's logical. Like if a person is not having TB and we are making anti-tubercular drug, so how we will come to know whether it works or not? So efficacy cannot be tested in phase 1. So phase 1 is in healthy people. Then we do phase 2 first time in patient. So when we do first time in patients, we are checking the efficacy first time. First time efficacy we are checking. So preliminary evidence of efficacy comes in phase 2. But it is only giving an indication, a hint that the drug may be efficacious, but it is not confirming this fact because it is done in a few patients only. Then phase 3 is an extension of phase 2 only, in which we do same thing but in large population, maybe 1,000, 2,000, 5,000 people. So here it is for confirmation of efficacy. So remember, phase 3 is for confirmation of efficacy. So remember, phase 2 is for first time efficacy, phase 3 is for confirmation of efficacy. And if they specifically ask which is efficacy trial, the answer is phase 3. Phase 3 are known as efficacy trials. In fact, the full name is something more to the efficacy. You can remember, this is a journal, Key Concept of Clinical Trials, postgraduate medical journal hai. So this journal, it is giving the reference here that phase 3 trials we demonstrate drug safety and potential efficacy, also referred to as a therapeutic confirmatory or comparative efficacy. So here we are doing the comparative efficacy. So pivotal trial is the other name of this trial, whereas phase 2 trial is not called any efficacy trial. It is called as therapeutic exploratory trial. They are not called efficacy trials. So phase 2 is therapeutic exploratory, phase 3 are comparative efficacy, therapeutic confirmatory or pivotal trials. So as such, just efficacy trial is not a right word, it is comparative efficacy trial. So hopefully the concept is clear. Efficacy is done in both phases, phase 2 as well as 3. Phase 2 first time, phase 3 it is confirmed. So saying phase 2 is an efficacy trial is wrong. Okay, so this controversy is clear, right? Right. So now we will move to the next question. This is another question. A patient with renal insufficiency had a very low urine output. Read carefully. Very low urine output, pedal edema, headache, and a blood pressure of 160/90. So that means it is a hypertensive patient with renal failure, which is severe because urine output they are saying is very low with pedal edema. So antihypertensive of choice they are asking. So first I will explain you the things, then we will go for some references. If you see aliskiren, we all know the name says it is inhibitor of renin. So all the drugs which inhibit renin-angiotensin pathway, they cause hyperkalemia. Remember, renin-angiotensin pathway secrete aldosterone, and aldosterone cause removal of potassium. So any drug will stop that pathway. That means it may be renin inhibitor, it may be AC inhibitor, angiotensin receptor blocker, beta blocker, aldosterone antagonist. Any drug which stop renin-angiotensin pathway is likely to cause hyperkalemia, and this is a major concern in severe renal failure. Remember, kidney is already failed. It is not able to excrete potassium, and drugs causing hyperkalemia will be harmful. So these drugs should be avoided. So renin-angiotensin pathway inhibitors are avoided in severe renal failure. Okay. Then coming to chlorthalidone, it is a thiazide. And remember, thiazides are not effective in severe renal failure. Thiazides are not effective in severe renal failure except the one which is metolazone. This is a previous year question also. Metolazone is the only thiazide which remain effective in severe renal failure. So if we want to control blood pressure by diuretic in a severe renal failure patient, we will choose loop diuretics. Thiazides are usually not effective. Then amlodipine is the answer according to me. It is safe also. Prazosin normally cause postural hypotension, and it is not a first line drug for hypertension, and the risk of postural hypertension further increases in severe renal failure. So answer according to me is amlodipine. But what is the controversy here? The controversy is that the several institutes, they are saying that amlodipine cause pedal edema. Amlodipine cause pedal edema. So we cannot use amlodipine. So I agree. Amlodipine causes pedal edema, but this pedal edema is not harmful. It is not a contraindication of using amlodipine. It is a harmless side effect. I will show you the reference also. And another thing, they are saying chlorthalidone is the answer because chlorthalidone is used in hypertension. Yes, it is used in hypertension, but it is not effective in severe renal failure. So I will tell you both the references. The answer according to me is amlodipine. So if you see the reference here, this is reference of Goodman and Gilman. So it is clearly saying effectiveness of thiazide as diuretics or antihypertensive is progressively diminished when the glomerular filtration rate falls below 30. One exception is metolazone, which retains efficacy in patients with severe degree of renal insufficiency. So clearly telling that thiazides are not effective in severe renal failure. Then second thing, this is about amlodipine, same Goodman and Gilman. They are saying that peripheral edema are the main unwanted effect. So peripheral edema is the main side effect of amlodipine, but fewer patients appear to experience this harmless side effect. So they are clearly telling that this is harmless side effect and amlodipine is not contraindicated due to this side effect. Okay, so this question is clear. So answer to this question according to me is amlodipine only. Moving to the next question, which of the following is true about PEG-Filgrastim, pegylated filgrastim. So what is the important thing to remember? Filgrastim, as the name tells us, it is a granulocyte stimulator. The name says it is a granulocyte colony stimulating factor. Now the main drug which is GCSF is filgrastim, as the name tells. But there is another drug called as pegylated filgrastim. So what is the difference between filgrastim and pegylated filgrastim? Pegylated filgrastim is containing PEG, which is polyethylene glycol, and this is added to the drugs to make them long acting. Like I commonly tell कि PEG लगा के आदमी लंबा चलता है, दवाई तो चली जाएगी. तो pegylated drugs are long acting. So PEG-Filgrastim is longer acting than filgrastim. One is clear. Okay. Now what is the controversy here is it is contraindicated in patients with sickle cell anemia. So this is the controversy here. It is not a controversy. Actually, pegylated filgrastim as well as filgrastim, they can precipitate sickle cell crisis in these patients. So it is avoided or given very carefully because they can precipitate a crisis in these patients, but this is not a contraindication. So remember, you need to see this option very carefully. If any other option you can find is correct, mark that as an answer, because sickle cell anemia is not a contraindication. Pegylated filgrastim or filgrastims are avoided in sickle cell anemia, but they are not absolutely contraindicated. The other options, it can be given orally, is wrong. Remember, both of them are injectable. Then not effective in severe neutropenia is again wrong. Yes, they are used for neutropenia. That is their main use. So two options seem to be correct in this. One, it is longer acting, and second, it is contraindicated in sickle cell anemia. Be very careful. If both are correct, contraindication is not an absolute. So the right answer will be longer acting. Okay, so according to me, the answer to this question will be a longer acting, but you need to choose according to the options. Now I can show you the reference here. So this is the package insert of PEG-Filgrastim, the paper which comes along with the drug itself. So that package insert is saying that fatal sickle cell crisis have occurred. That means it can cause sickle cell crisis, but from the same package insert, it is written later on in detail that severe and sometimes fatal sickle cell crisis can occur in patients with sickle cell disorder receiving PEG-Filgrastim. Discontinue this if sickle cell crisis occurs. So that means clearly they are telling they can be used in sickle cell anemia, but whenever this crisis occurs, we need to stop them. So they should be given carefully. They are not contraindicated. Okay, so this controversy is also crushed, right? So let's move to next question. So next question, Tourette syndrome and ADHD with Tourette syndrome or tic disorder. So what information I have found about these things is the drug of choice for Tourette syndrome, whether it is with ADHD or without ADHD. So both of them, the drug of choice is clonidine. Clonidine can treat both ADHD also and it can take also, that means Tourette syndrome also. Clonidine is a drug of choice, but what is the catch here? Clonidine is not FDA approved. Not FDA approved. Remember, US FDA approved drugs for Tourette syndrome are only 3 drugs. These are haloperidol, pimozite, and aripiprazole. Only 3 drugs are FDA approved for treatment of Tourette syndrome or tic disorder. But the studies have shown that although they are effective, but they cause a lot of side effects. Like haloperidol is associated with a lot of extrapyramidal symptoms. So these are not commonly used by the physicians. So physicians are using some other drugs which are not approved. Even still they are using them. So these are called as off-label use. Off-label means the drug is not labeled for this indication, means approved for this indication, but we are using it. So clonidine is one drug which is commonly used for this indication, and it is in fact the first line drug. Whereas if the question is asked, read carefully, if the question is asked which is FDA approved drug for Tourette syndrome, then answer should be one of them. But if they ask which is the first line drug or which is drug of choice, I will go with clonidine. So reference I can show you. This is the current treatment of Tourette syndrome, Journal of Pediatric Pharmacology and Therapeutics, 2000 and 20, quite latest journal. So here it is showing very clearly that Tourette syndrome is a hyperkinetic movement. All details are given. So if you go to the details about this, in this it is saying that clonidine is alpha-2 adrenergic agonist like clonidine and guanfacine are the first line pharmacological option. They are first line pharmacological option, and FDA approved drugs I have already told only 3 drugs. Okay. So I hope you will choose the answer wisely, read carefully whether they are asking FDA approved or they are asking first line drug. So this controversy is also crushed, right guys? So let's move to next one. So this is a new guideline. So there is no controversy as such. So new guidelines by the IPSAT. So these are the IPSAT guidelines. International Society for Pediatric and Adolescent Diabetes. So IPSAT guidelines, what they are telling that in children with diabetic ketoacidosis. So what are the special thing you need to remember? In children with diabetic ketoacidosis, 2 things to be kept in mind. Number 1, intravenous fluids are very important. Intravenous fluids, saline is very important, and it is important in adults also. We always tell fluids are more important than insulin in diabetic ketoacidosis because dehydration is the more damaging thing. So IV fluids are more important, and they are given as bolus. The dose you may remember, may not remember, 10 to 20 ml per kg over 20 to 30 minutes. They are given as bolus. But what is the special thing to remember is that they have told that insulin should be given after 1 hour of starting infusion. So in adults, insulin is given along with intravenous fluids, but here they are telling that insulin should be given 1 hour after starting IV fluids. Second important thing is, in adults, insulin is given first as bolus, then as infusion. 1 stat dose and then infusion is started, but they have said that bolus insulin is not given in children. In children, bolus insulin is not given. Directly IV infusion is started after 1 hour. So 2 things to keep in mind. In children, diabetic ketoacidosis, number 1, IV fluids are started first. Insulin is started after 1 hour. Second thing, insulin infusion directly should be given. Bolus should not be given. Yeah? So this is what the question is asking. So see the question. A 10-year-old child with a known history of type 1. So they are giving diabetic ketoacidosis. So what they are saying that initial treatment with IV fluids has been started. So what is the next management? So see here, they have started IV infusion, IV fluids, but they have not told that how long ago they have started. So they initiate insulin intravenous infusion. So I will not mark this answer because IV fluids have been started, but when they haven't started, I don't know. Okay. Then give insulin infusion. Insulin stat at a dose of this, that means bolus dose. No, this is not recommended in the new guidelines. Then administer normal saline for the first hour followed by insulin infusion. So that is the right answer. And continue IV fluid without insulin, that is a wrong thing. Obviously, insulin is required for diabetic ketoacidosis. So hopefully this guideline you all know already. So I'm just revising these guidelines, not much controversy if you know these new guidelines. So these are in children. Okay. Now moving to next question, drug of choice for treatment of bleeding esophageal varices. So again, the controversy here is some people are saying Terlipressin is drug of choice, some are saying Octreotide is drug of choice. Both can be used, but I will go with the books. In CMDT, it is very clearly written Terlipressin is a drug of choice wherever it is available. So if it is available, it is a drug of choice. So if examiner is giving it in the option, so examiner is assuming that it is available. Okay. So if Terlipressin is in the option, mark Terlipressin as drug of choice. So you can see the reference here. The reference, it is CMDT very clearly written. Terlipressin may be preferred to Octreotide for the treatment wherever it is available. Preferred to Octreotide. Wherever available, Terlipressin should be used. Okay. So moving to next question. Drug of choice for treatment of Parkinsonism is, this I keep on telling again and again several times. It's been many years now. So for Parkinsonism, now the drug of choice is dopamine agonist. Dopamine agonists are drug of choice like pramipexole and ropinirole. Pramipexole or ropinirole are drug of choice for Parkinsonism now. They are preferred over levodopa. But if they ask which is the most effective drug for Parkinsonism, most effective is always levodopa-carbidopa combination. So read carefully whether they are asking most effective or they are asking which is drug of choice. So we always start with pramipexole like drug. If the patient is not controlled, then we can add levodopa-carbidopa combination. Next question, what is drug of choice for drug-induced Parkinsonism? Drug-induced Parkinsonism, everyone knows. Yes, the drug of choice are central anticholinergic drugs like benzohexole. Benzohexole, the other name is trihexyphenidyl or THP. It is a drug of choice for drug-induced Parkinsonism. The alternative to benzohexole is promethazine. Promethazine is an antihistaminic with very strong anticholinergic property. So trihexyphenidyl is for drug-induced Parkinsonism. Levodopa-carbidopa is most effective but not the drug of choice. Pramipexole is the answer here. It is a drug of choice. Okay. So again, you can see a reference. So this is Harrison. Harrison is writing that dopamine agonists such as pramipexole, ropinirole act directly. They are effective in both early and advanced stages. They are often given either before the introduction of levodopa or with low dose of cinnamon. So that means before levodopa means they are first given. So they are obviously drug of choice. Okay. So this controversy is also clear, right? Good. So moving to next question. The next question is signal transduction mechanism of vitamin D. So this is a controversy since years now. So I will want to clear this controversy that intracellular receptors, they are also known as nuclear receptor superfamily because all the receptors which are inside the cells finally work through nucleus. So intracellular receptors are divided into two types, cytoplasmic and nuclear. Cytoplasmic receptors I commonly tell are CD. C means corticosteroids. Corticosteroids, that means mineralocorticoid, glucocorticoids. Whereas D means vitamin D. So vitamin D is a cytoplasmic receptor. On the other hand, nuclear receptors we remember as SAT, SAT. So S means sex hormones. So the receptors of sex hormones like means estrogen, progesterone, testosterone, and vitamin A and thyroid hormones. So these are nuclear receptors. So you can remember कि Saturday को SAT मतलब Saturday को सेल के अंदर बैठ के CD देखते हैं. कौन सी देखते हैं मुझे नहीं पता, आप लोगों को पता होगा. So this is how to remember. So which are cytoplasmic, which are nuclear. So vitamin D, it is a cytoplasmic receptor. Read carefully, it is a cytoplasmic receptor and it is a member of nuclear receptor superfamily because it is one of the intracellular receptors. Now what is the controversy is, some books and some institutes are saying that vitamin D is a nuclear receptor because that is written in the Harrison. So I will show you what is written in the Harrison and what actually vitamin D receptor is there. So if you see, this is Harrison. So what is Harrison saying? 125 dihydroxy D. That means vitamin D mediates its biological effect by binding to a member of the nuclear receptor superfamily, the vitamin D receptor. So probably that institute has not read it properly. So they are saying that vitamin D receptor is a member of nuclear receptor superfamily. Remember that superfamily includes cytoplasmic also. Now this is confirmed by the Goodman-Gilman, which is very clearly writing. What is Goodman-Gilman writing? Vitamin D receptor calcitriol bind to cytosolic vitamin D receptor within target. Cytosolic, that means cytoplasmic. The vitamin D hormone complex translocate to the nucleus and interact with the DNA. So it's very clearly writing that it is present in the cytoplasm. When vitamin D bind, the complex moves to the nucleus. So it is a member of nuclear receptor superfamily, but actually the receptor is present in cytoplasm. So there is no confusion regarding that. Okay. Now, second thing you need to remember, there is another controversy on the sex hormones. So this is not a controversy. Just to make it easy, I tell you that all three are present in the nucleus. But if you want to remember more details, so I will tell you that estrogen is purely nuclear. All estrogen receptors are only in the nucleus. Whereas progesterone and testosterone receptor, they are present partly in cytoplasm and partly in the nucleus. Clear? So read the options carefully and then choose. So if they are writing that androgen receptors are present in cytoplasm and no other option is correct, so mark that. Okay, but if some other option is also correct, then choose that option. Okay, so read carefully. Progesterone and testosterone receptor, that means androgen receptors, they are present both in cytoplasm as well as in nucleus, whereas estrogen are purely nuclear receptors. Vitamin D are cytoplasmic receptor, not nuclear receptor. Hope that controversy is crushed, right? No confusion regarding this. So let's move to next question. So this is another question which had been asked recently. They were saying that a female was taking lithium. She is about to deliver a baby. So what should be the dose adjustment just before delivery? So just before delivery, just remember, decrease the dose of lithium to avoid the toxicity in the baby. So do not go into too many details like what will happen to blood volume during third trimester, what will happen after delivery, what will happen to level of lithium, what will happen to this, that. Do not go into those details. Just remember, lithium toxicity is likely if we continue lithium during late pregnancy, particularly the third trimester, few days before delivery. So it is always advised that just before delivery for 2-3 days, stop lithium. And if we cannot stop, at least decrease the dose of lithium. So this is the reference given. This is Williamson's. Williamson's is saying that neonatal lithium toxicity stems from exposure near delivery. The manufacturer recommends that if possible, the doses should be decreased. The doses should be decreased or drug discontinued 2 to 3 days prior to delivery. Okay? So this is very clearly written in Williamson that the dose should be reduced or the drug should be stopped. Okay, so moving to next question. So this is one of our mnemonic that has been used by the student themselves to generate a controversy. This is not a controversy at all. So basically, what is the question? A 45-year-old patient with a known allergy to penicillin comes with enterococcal endocarditis. So we have to choose a drug where the drug is drug is safe in a patient who have allergy to penicillin, and the drug is effective in enterococcal endocarditis. Now, what is the confusion here is the students are saying that azithromycin, इसके नाम में लिखा है अजी तेरा नाम तो बता. I told you why the people are going, penicillins were going to this drug and saying अजी तेरा नाम तो बता, because this is different from them. That's why they were curious. Why it is different? So they were asking it, Aji tera naam to bata. So what is difference? There are two differences I told very clearly. One, it do not show cross allergy. It do not show cross allergy. Cross allergy is not there. That means it is safe in patients who are allergic to penicillins. Can be safely used. So just looking at this, now many students are saying that answer should be azithromycin. No. Azithromycin से हमने नाम क्यों पूछा जी तेरा नाम तो बता, because it has one more difference that it is only effective against gram negative bacteria like Pseudomonas. It is not effective against gram positive bacteria. Penicillins were only for gram positive. This is only for gram negative. So it is not effective against gram positive bacteria like Enterococcus. So it is not effective in endocarditis. So this is not used because it is not effective. Although it is safe in patient allergic to penicillins, but not effective in this patient. Then ceftriaxone is a beta-lactam. So it will cause allergy. Piperacillin is a penicillin. It will cause allergy. So these are ruled out. So answer is vancomycin. Remember, number one, vancomycin is not a beta-lactam. Because it is not a beta-lactam, so there will be no cross allergy obvious. So vancomycin is safe in this patient. Number two, vancomycin is mainly for gram-positive bacteria. We know it is drug of choice for MRSA. So it is gram-positive bacteria and it is effective against Enterococcus also. So in a patient who is allergic to penicillin, the drug of choice will be vancomycin. I hope this controversy is crushed. Right, guys? Let's move to next question. So this is the question. If you read carefully, you can answer this. The question is, which anticoagulant and its FDA approved antidote is not correct? So we have to tell anticoagulant and their antidote. I commonly keep on teaching that dabigatran. So I can make a table here. We have warfarin. We have heparin, means unfractionated heparin. Unfractionated heparin. Then we have dabigatran. And we have hexabans. Lot of drugs whose name end with hexaban, they are 10A blockers. The antidote for warfarin we all know is vitamin K. For heparin we all know it is protamine sulfate. protamine sulfate. For dabigatran, we have a monoclonal antibody called as idarucizumab. Idarucizumab is a monoclonal antibody against dabigatran, and for hexabans, the drug is Andexanet. Andexanet alpha. So Andexanet, the name itself tells it is antidote. And is antidote for 10A blockers or neutralizers. Antidote for 10A neutralizers. So 10A ban, hexabans are 10A blockers. So antidote for them is Andexanet. So all these are FDA approved. But there is one more drug which is called as Siraparantag. Siraparantag. Siraparantag is a non-specific antidote. It is antidote for most of them. It is antidote for unaffected heparin also, hexabans also, and it is also for low molecular weight heparin and fondaparinux. So it is antidote against all of them. Theoretically, in the laboratory, it has been found to antagonize the action of all of them, but it is not approved. It's a long time now, Siraparantag is still not approved. So it is only experimental drug, not used clinically. So now read the question carefully, which is not correctly matched. Idarucizumab, so DA means dabigatran, so it is right. And Andexanet alpha, 10A blocker, so hexabans, that is right. Siraparantag, fondaparinux, although it is right, but it is not approved, not approved. And Andexanet, apixaban, again hexaban, this is right. So answer is Siraparantag and fondaparinux. Although this is antidote, but this is not FDA approved, and this is not used clinically at all. Okay. So moving to next question. This is a question on rickettsial infection. The question was asked, and there was scrub typhus, I think. So in this question, they have given the symptoms of pneumonia, and they are asking what is the treatment. So it is very clearly written in the question, suggestive of atypical pneumonia that may be related to her primary infection. Primary infection was scrub typhus. So the drug of choice for scrub typhus is, yes, it is a doxycycline. So whether you will give only doxycycline or you will treat atypical pneumonia by azithromycin also, that is the controversy. Will you give only doxycycline or you will give doxycycline plus azithromycin? Very good. Answer will be only doxycycline, because here it is saying that atypical pneumonia is related to primary infection. That means it is rickettsial infection only which is causing atypical pneumonia. So answer will be intravenous doxycycline only. Remember, do not add azithromycin unless you are suspecting that mycoplasma or chlamydia is also causing the infection. Okay. So the answer is doxycycline only. Clear? So this is another question. A patient with diabetes and COPD develop post-operative urinary retention, and which of the following drugs should be used? Now see carefully, guys. What is the condition being asked? Condition being asked is post-operative urinary retention. So many students saying that the answer should be tamsulosin because it is used in urinary retention. But see carefully, is tamsulosin used in urinary retention due to BPH or due to any cause? So obviously it is used for BPH. But a problem, BPH, there is constriction of urethra. When we give tamsulosin, it will dilate the urethra. It is used to treat urinary retention due to BPH, but not for post-operative. In post-operative retention, there is tone is altered, tone is not there. That's why urine cannot be passed. So it will not be effective in treating the post-operative urinary retention. So tamsulosin is out. It cannot be the answer. Then methacholine is mainly used for myocardium. So methacholine is also out. Tirazosin is again alpha blocker. So bethanicol is the only drug. As the name says, acol. It works like acetylcholine on the bladder. So that means it will stimulate the bladder, contract the bladder. So treat the atonic bladder like that's shown in urinary retention. Now, what is the controversy here is bethanicol can cause bronchoconstriction. Remember, in the bronchos also M3 is present. It can cause bronchoconstriction and the patient is having COPD. So that can be worsened. So now the problem is what we will answer. Remember, other three drugs are not effective. So which drug we will choose? Only that which is effective. So we will be careful about COPD. So we will give this drug and we will increase the dose, or we will basically monitor the COPD status. If that is worsening, we can change the dose of bronchodilators and other drugs. Okay. So among the four, whichever is effective, first we will choose that. Okay. The answer here is bethanicol. Okay. So this is the old question now. Restless leg syndrome. Previously, the drug of choice was pramipexole, but now it has been changed to gabapentin. The drug of choice for restless leg syndrome now is gabapentin. So there is no confusion about this one. Okay, now it is gabapentin. The next thing is breast cancer. So hormonal things, hormonal like estrogen, progesterone, whether they increase the risk of breast cancer or not. So what is the concept you need to remember is estrogen increase the risk of breast cancer. Estrogen increase the risk of breast cancer. But progesterone, there is variable data. Some studies they show that progesterone increase the risk of breast cancer. Some studies they show they do not increase the risk of breast cancer. So the different studies themselves are not in coordination with each other. So this is a variable effect. We are not sure whether it increase or not increase. Then third is oral contraceptive or combination of estrogen and progesterone. Now OCPs may be very low dose of OCP. There may be low dose estrogen. There may be medium dose. There may be high dose. Remember, medium and high dose estrogen containing OCP increase the risk of breast cancer, whereas low and very low dose have no increase in risk. No increase in risk. So remember, medium and high dose estrogen containing oral contraceptive pills, they increase the risk of breast cancer. Estrogen if they give, obviously they increase the risk of breast cancer. And if progesterone is given, it is variable. Different studies are not in sync with each other. So depending upon the option. So my advice will be to read all the 4 options carefully. If there is any ambiguity regarding this, mark the other which is clearly the answer. Okay. So that is about the effect of different hormones on the breast cancer. Then hyperprolactinemia in pregnancy. First of all, without pregnancy, what is the drug of choice for hyperprolactinemia? What is drug of choice? Yes, it is cabergoline, which is a dopamine agonist. Cabergoline is drug of choice. It is preferred over bromocriptine. Because cabergoline is longer acting and also it is better tolerated than bromocriptine. So it is a drug of choice. Both can be given orally. Okay. Then what about in pregnancy? So remember, in pregnancy, both of them are equally teratogenic. The side effects are similar. So there is no difference between the side effect of these two in pregnancy. So what is recommended in first trimester in particular is we will try to stop both of them. If hyperprolactinemia is not worsening, the visual disturbances and other symptoms are not worsening too much, then we can try to stop them altogether in first trimester. And if we are not able to stop, then both are equally hazardous. Both have equal risks, but better tolerated is cabergoline and more effective, longer acting is cabergoline. So the drug of choice will be cabergoline. So whether it is pregnancy or it is not pregnancy, mark cabergoline as drug of choice. Okay. So drug of choice for refractory intractable chorea. So this is the problem that this question has been asked in different options. I don't know what is the exact option which are asked in the exam. So I will give you this sequence for chorea. First of all, we will use the drugs like haloperidol. Haloperidol like drugs are. If haloperidol like drugs are not effective, then we will use valproate or carbamazepine like drugs. If they are also not effective, then we will use steroids like prednisolone. And if that is also not effective, then we will use IVIG, intravenous immunoglobulin. That is the sequence what is given in the Harrison. So according to the options you will choose. So if they are asking intractable, that means which is not responding to anything, my answer will be IVIG. In this question, the answer will be IVIG, but depending upon the options what are given, you should choose the answer. So this is the reference of Harrison. You can see that in first of all, chorea, calm environment is the only thing, no drug need to be given. And if it is severe, then carbamazepine or valproate is preferred to haloperidol. So haloperidol is better, but if it is not responding, then in severe cases, carbamazepine or valproate. And after that, corticosteroids in severe refractory cases, corticosteroids like prednisolone for severe refractory cases, and intractable where nothing else is working, IVIG. So that is the sequence I will recommend, but I don't feel that this question will be asked. So these are the important controversial questions. So I hope many of your controversies must have cleared and many new must have emerged. So my advice is, do not waste time on these controversial questions. So just remember whatever you feel like it is suiting your brain, because we do not know from where the examiner has picked the question. Yeah? So what is the best my perspective that I have told you in this, and if you have any query, feel free to ask. Thank you very much.